Thanks. So thank you all for having us today. Brian and I are going to try to keep you entertained by switching things back and forth quite a bit. But we want to really have a conversation. We know a lot of folks went through similar scenarios when it comes to telehealth and that rapid implementation, not because we all wanted to implement rapidly, but really because we had to in order to survive and provide great care to our patients. So we'll talk through some of those scenarios with you today. Next slide. And you'll hear me say that because Brian, the IT whiz, is in charge of the slides. So if there are any slide issues, we can also reference that Brian, the IT whiz, is in charge of slides. So with that, today we want to talk through our telehealth pre and post-COVID, how we expanded our technologies, the impacts that we saw and our lessons learned throughout the process, patient considerations, and where we're going next. Next slide. So when you think about where we started, I'm guessing many of you were in the same boat, but maybe further along. Just to give you a sense of pre-COVID, where we were at in our telehealth journey, we had started the conversations around telehealth with many of our providers, but hadn't seen that buy-in from them. So the focus was really with our primary care providers, and just about 2% of our providers were actually using telehealth. We had a total of a whopping 100 monthly visits that we were offering to patients, and Epic was our primary platform. So we didn't really, one piece that we feel really impacted this was rules and regulations. And I came in a little bit into the prior discussion, and some of those things were being discussed there as well. When we think about that, we lacked our payer consistency. So knowing which payers would cover telehealth and what scenarios, how did we document, what did we need to bill? And we feel like that definitely had an impact on why our progress was a little bit slower, and then looked at the incentives to providers. So if they weren't going to be reimbursed for the work that they were doing, where was the value in being able to offer that to our patients? So definitely one of the big pieces that not only was impacted by COVID, but would be something we would look to in the future to try to understand and could impact our telehealth numbers again if that scenario changes. Next slide. And I'll hand it to Brian.
Yep. So I think when we all reflect on what the pandemic and the lockdown ultimately turned into, this will be one of those moments in history that our grandkids will say, do you remember where you were when the pandemic occurred and what happened on those days? But Brooke and I have assembled a couple different views of how that timeline unfolded. I'm sure that many of you will find parallels in this. I think back to my own time with HIMSS and a presentation I saw from Tulane down in Louisiana when Hurricane Katrina went through, and all the lessons that they learned and how we took those exercises forward. And I think some of what we'd like to share here in our response is really how you mobilize a large, complicated institution into something very quickly, and where some of that became a grassroots effort. So really at a summary level, the moment that the pandemic became very real, and probably in the days even before the national emergency was declared, we started to recognize we had certain supply challenges. And we all well know now many pieces of critical hardware were lacking. So initially we had to put a scope around getting supplies, calling for laptops to come in from employees who were going home, and sending those employees, those non-clinical employees, home with desktop PCs, with USB Wi-Fi or other types of connections, but still encrypted, still meeting all the same security standards, but really taking laptops back for telehealth programming. Our scope was pretty large. We had over 750 cameras to get out at a time that cameras became a little bit difficult to procure. We had a software push that we had to do to help enable some of our connectivity with Epic and supporting some of the ongoing expansion that we had there. We also had to look very closely at our telehealth footprint. As I'm sure many folks on the phone here know, we were using, or you were probably using, solutions in Epic that are embedded directly in the software and require the use of Epic's patient portal, MyChart. So we had a population of patients who may not have been affiliated with Ohio State before, may not have a MyChart account, and we began to look at how we might expand functionality to meet some of those needs. And then, of course, sustaining that. In addition to our billing providers, our MDs, we had a whole contingent of APPs and therapists, other clinicians that we needed to get that software and training out to and begin to monitor some of that. So really breaking that timeline down, at the time the pandemic occurred, we really initially started by pulling a couple of leadership groups together to talk about how to tackle this and what needs we had, what opportunities we'd have ahead, and starting to mobilize some of the physician leadership to message in their own departments the importance of this shift into telehealth. Going into that second week, as we started to identify some of the limitations or just barriers in technology, things that we now know, we can help improve on, we started to look at how we fill in some of those gaps. And that led into the discussion about rolling out technology, finding a vendor. In this case, we went with UpDocs, who was a great partner for us in deploying a very rapid solution that helped mitigate some of the problems we had in just previous patient engagement with some of our patient portal technologies. And then, of course, communicating with our chairs. As I'm sure folks on the phone here will appreciate, we very quickly recognized we had some revenue issues looming and clinical volume issues if we didn't buffer that by enabling telehealth as quickly as possible. So a lot of that was done with messaging out to the departments about where their clinic volumes stood, how that was being now mitigated with telehealth opportunities, and continuing to reinforce that through self-service leadership reporting portals, those sorts of things. By week 4, I can't really say it otherwise, but it was the new normal. Starting to make sure that we're going through that iterative process of identifying gaps, trying to figure out where we've got hotspot areas that may need additional help, continuing to put out the call for more cameras. We ended up taking a company courier and shuttling that person around to employee homes because we found we had some cameras deployed out prior to COVID that we could repurpose into this initiative to help get that technology out. Getting telehealth targets in, trying to set goals that as we got that far along in the pandemic really started to help us understand where we were falling short on regular clinic volumes through the creation of a telehealth immediate care center, trying to understand where we could help drive volumes back in and re-engage patients in new ways. And then week 5 has really continued. Even after the state started to open back up, we still have these portals live. We're trying to manage telehealth as an ongoing strategic delivery method for the institution. And you'll see here in just a little bit of how Brooke is helping to help facilitate some of that. Within technology, I don't think I need to say that, cameras, headsets, and even connectivity were all initial, problems. We had clinicians who had gone home and complained of, slow network speeds, which we're hearing from the carriers now. I think Verizon in particular noted they saw a 75% increase in some of that local traffic out of neighborhoods when everybody went to work from home. Headsets, we made the trip to Micro Center. We hassled every vendor we've got who fortunately worked to prioritize headsets and cameras towards healthcare customers. But we did get a little creative. We reached out and we talked about, pilfering Xbox headsets out of, the kids' bedrooms or, using earbuds and those types of things to help facilitate, communication there. With regard to software, there was a whole new creation of scheduling and clinical workflow that we had to think about. As Brooke pointed out, only 2% or so of our providers had actually used telehealth, and we hadn't really had enough internal interest to receive a lot of optimization types of requests. And the pandemic very quickly incentivized or created a lot of new interested parties in how we could continue to optimize that very quickly. We had the problem I mentioned with patients who had not had access previously to the patient portal. And so UpDocs, filled that gap for us. But what we were finding from our patients is they may have lacked the appropriate model of an iPhone, or maybe they didn't have, a broadband connection to actually help support some of that content. And we're still looking at ways that we can work with underserved populations and expand that, because that need is not going to go away, as I think we've heard with public schools and healthcare, other underserved areas. As far as training and troubleshooting, one of the key problems is we were almost setting up a retail store-like presence, like the the desk in the Apple store at a Verizon store when you walk in for help, but we didn't have a counter. We didn't have a physical location for people to come and talk through what they were seeing on their phone and how to enable a microphone or how to enable, the video camera on their phone. So we ended up using the web portal quite a bit to help do testing. The vendor, UpDocs, for example, enabled a website where you can actually test your visit. Prior to that, we ended up putting that on our corporate website. We've done a lot to try to enable the help desk here at the medical center. That's part of our patient portal. So when patients call in, we can actually do some mild troubleshooting on how to set up microphone or how to set up camera permissions. And then, of course, the communication effort. We have a fantastic digital strategy department who had some great ideas, and they had to work very quickly and agilely to help get that out there as we determined how to message it, who we could target it to, and whether it was local media or the website, or even just educating the clinics to, help encourage patients to use this alternative form of healthcare. It was a very massive, very agile effort there. Just briefly, I thought I'd kind of highlight some things to think about if you're trying to work very quickly through a complex, software decision, something like that. At the time that our physician president walked in and said, hey, we've got to do more to enable telehealth, understand what we've got currently in the environment, where we may have gaps. Some of the processes that might have normally happened in more of a sequential order started to happen in parallel. And that included, of course, the contract reviews for some of the new technology, getting a risk assessment completed, and then initiating the project request. And of course, each one of those tasks then begat subtasks that then had to follow from that. In looking at IT requirements, we had to enable changes in our firewall. OSU takes security on the network very seriously, as we've continued to review here even this past week with the ransomware event, and just revisiting and thinking about those things. We had to make sure that we had streamlined or optimized connectivity for our telehealth software through the firewall. Getting user accounts created, with thousands of employees and all sorts of different roles, it was making sure that we had understood exactly how to enable that. And in some cases, just making an optimized decision that may not have been perfect, but it was good enough to get us moving forward until we could come back and revisit it. We had to think about training, and I can't really say enough about training other than that you have to train everyone. You have to train clinicians on how to use it. You have to train their staff on how to support them. You have to help educate patients on how to connect on the other side. We've learned a lot, in the past 6 months that we're now still continuing to optimize going forward. Of course, with marketing, getting out and talking about that, I've touched on that just a moment ago. And then in our situation, we actually set up a call center specifically around telehealth. Brooke had sent a number of her team home, from a call center type environment that was, historically central scheduling, and we had to turn that right back around into an immediate care office so that clinicians could come and work in a private environment, get nursing support for some of the patient triage questions, and enable video visits very quickly there. As part of doing that, we had to revert to a lot of email communication to help get messages out, holding meetings or doing virtual sessions, to try to encompass that many people just wasn't really an option for us. So a lot of that was a personalized email that came out with links inside the intranet of the medical center to where they could get information and then call for assistance on it. Not surprisingly, we learned a lot. And I shared this last little screenshot because we had a pretty well-positioned physician in the organization who had reported that they had nothing but black videos coming through for their patients. And we had to point out there's a slider on a laptop. And it seems so simple at this point to say that, but we really did not have a lot of exposure around video technology at that point. So we had to almost work through that triage and troubleshooting process in the help desk to make sure we were thinking through all the smallest things about why video needs to work and how to help it work efficiently.
So thank you, Brian, for that great detail. I'll add a little bit to that, and I think Brian did a great job about talking of the training that we implemented. We have, I think, the biggest opportunity to engage our patients and our providers and our clinics to make this successful was really around the training process and what we did. So the emails and the information, but we also did video video sessions with our frontline team members, because we knew our providers weren't always going to be the ones who could absorb all of that information, and they didn't want to be the IT person for a patient who's having difficulty, right? They wanted to go to the person, but hopefully beside them or virtually, who was supporting them and say, how can we fix this? So I recall one session that we had over 300 team members ranging from physicians to frontline staff members on this, discussing how we would manage our workflows around telehealth. And we had a multitude of those events going on so that we could really see what questions were out there and learn from those. And what you can see here on the visual that Brian is displaying is really the impact that that had on our organization. So when we think about the volumes, and I'm sure when many of you look at your volumes, you can see that overall, we had started with 2% of our providers offering telehealth, and we went to 90% of our providers offering telehealth. We went from 100 monthly visits to over 2,500, and at points, that weekly number became daily, over 2,500 visits being completed. We were able to get $13 million in net revenue from our telehealth activity alone, which is significant. On the visual, you can also see that we didn't meet our pre-COVID projections, but we got a heck of a lot closer to that number than we would have if we didn't have telehealth. So we continue to see this being a foundational aspect of care, not only for our patients who are wanting it, but also our providers who want to be able to offer it. Next slide. In this slide, I just wanted to talk about the mode. So we had talked about, we had 2% of providers joining and offering telehealth, but really when we think about that, most of that was being done via phone pre-COVID. That was where they were comfortable at. That's where our patients were comfortable at. So when you think about the gap that we had to go through in knowledge learning every step of the way from March to April, from really no video visits to 35,000 video visits being completed, it was significant. And we also wanted to push video. One, we wanted our patients to feel more engaged with their providers. Two, we wanted our providers to be able to ask and visualize some of those scenarios with the patient. Sometimes discussing something, you need a patient to point or show you. And video may not be the ideal scenario, but it's better than no video. And at times, I think now we may be getting to the place where our patients are even a little more comfortable with video than they should be. And we have to remind them of where are appropriate places and scenarios to be sharing video with your physician. But this is just a really great visual to reflect that. We can see overall our numbers have trended down, but like we wanted, that video is still the primary interaction. We aren't ever going to get rid of telephone, we don't think, because we do have scenarios that require it. Right now, for our patients who need an interpreter, we are using telephone primarily. Although video is an option, the process is a little bit challenging for our patients and providers to understand. Hopefully that will change in the near future where we can get video up for those, but also just economically what our patients are able to utilize. They may not have the technology or resources to be able to complete a video visit. So we do want to be able to offer telephone as an option to our patients to make sure that we're offering that care no matter what the scenario or requirements are. And then back to Brian.
All right, so following up on lessons learned, we always like to understand what we're connecting with and what the impact is. one of the interesting points on our payer mix was the dramatic increase in our managed care opportunities. A number of those patients really, championed and led that video visit connectivity with us. We also saw an increase in our Medicaid patient population, and that's a very important group for Ohio State, and one that we were pleased to find the connectivity with. Overall, we did see Medicare volumes drop off, and that's something that, whether we're looking at the demographic or just really as a percent of total, it helps us understand where some of the opportunities are and how we can better connect with the patients that need care, particularly in these troubling times. Other impacts, no-shows are a big watch area for us. Every no-show is a missed opportunity, both for the patient as well as the physician. And what's interesting about some of our no-show activity, looking specifically by modality, telehealth versus overall, you can see that we cut the no-show rate about in half, that 8.8% down to just over 4%. Patients connect with us via telehealth, and they seem less likely to, ignore, forget, or miss those events. Certainly if it's a transportation issue, or perhaps, there's a weather-related, barrier or something, we seem to be able to have a better connection with our telehealth patients that way. And Medicaid in particular, who had historically had a 12.5% no-show rate, we were able to drop that down to 8.6%. So another dramatic improvement, and I think a great reason that telehealth will be an ongoing strategy for us as we look to better serve patients where they are and how they like to connect with us. Some provider pain points that were active right away, and then things we continue to look at, starting from the top and around. Stable connections. Certainly delivering telehealth requires that we've got a solid connection back and forth. And not surprisingly, as I mentioned earlier, during the pandemic, we had local connectivity issues in certain neighborhoods that carriers had to follow up on. We had to talk with providers to make sure they had enough bandwidth. They may not have purchased a large enough, home service, prior to the pandemic to help service telehealth activity with. The carriers that some of our, video visit technology vendors are running are all starting to use common protocols, and some of those protocols all run through gateways with the host service. And so making sure that those vendors are beefy enough or have failover points to give stable connections is become increasingly important, critically important, as we talk back with our vendors about how to improve services. The end user learning curve, generationally, we've got a lot of different people, both on the patient and the provider side. Some of those folks may or may not have used FaceTime or other types of video, visits in the past. So making sure that those folks are comfortable with what they're being asked to do and have enough information. Multi-person visit limitations. We've had a number of situations where, providers or patients have come forward with a need to bring a family member, a consulting physician. In our case here at Ohio State, we have a teaching opportunity. We'll sometimes bring students into the conversation, and making sure we understand how the technology can enable those things and facilitate a critically important part of our institution. Rapid training. I mentioned we had email as a primary vehicle, but trying to develop good training material that's been properly vetted, documented, and supported is tough. And we put a huge weight on our training and optimization teams, as well as digital marketing, who had a hand in that as well, all who responded incredibly. But I think it certainly highlights an area that without having that ability to do rapid training, we would have suffered a little bit more. That said, we still have opportunities there. We had providers that, they're kind of working in a day-to-day environment, and we were forcing that environment to shift. We can't really under-communicate as we try to deploy training information at that point. Then, of course, changes, something we continue to monitor, state licensure, billing, scheduling changes, whether it's the creation of a new visit type or trying to understand which patients are connecting from outside of the state of Ohio and how that affects our billing process has been an ongoing exercise for our coding department, the compliance department, and then working with Brooke's team to help facilitate infrastructure, and then messaging out, of course, back to the providers about things they need to be aware of. So we had to very quickly adjust a team and reprioritize efforts that they were involved with pre-pandemic to support that process. Brooke?
We also wanted to talk about some of the goals. So, as we look at telehealth, we knew that we wanted to build this into our foundational expectations for our providers to be able to make sure that we built them into their templates and that we were able to offer that option to patients consistently. So, some of the pieces we started with were those specific goals related to telehealth. Overall, organizationally, for this year, we've set our goal at 15% of our patients receiving care through telehealth. So having a completed visit. We did break that down by different specialties. So for our primary care group, they had a higher goal. Our medical specialties were in the middle, and our surgical specialties had a lower goal, knowing that based on their needs, we had to find the niche for them and what was really reasonable. There are still subsets of groups that aren't necessarily meeting those goals, such as our ophthalmology group. Part of that is because it was a general goal that was bucketed out to groups, but for ophthalmology, there are a lot of specifics that need to be done, such as testing or the view that needs to be seen needs to be really detailed for the eye. So when we think about those options, telehealth maybe wasn't the best fit, but we could have a drive-through tent that we set up for those patients, or expanding our clinic and really making sure we are socially distancing there. So you can see overall for the organization through September, still strong numbers, 24.9% of our visits being completed via telehealth cumulatively. And then you can see the volume trending down there. Some other pieces that we did is we really built it into the templates and the schedule. So making sure that our providers and our capacity management teams were working together to identify how much telehealth should be in the schedule and where. So is that a mix of telehealth and in-person, telehealth only, in-person only? What are the provider needs? What are the specialty needs based on just the concerns for their patient populations? And then building that out so that patients can also do self-service as much as possible, letting that patient decide whether they want to have that visit via telehealth or in person. And we were able to offer that through MyChart, and to a certain degree with our telehealth immediate care clinic online to non-existing patients. So really bringing in new patients with the option of telehealth as well. So that's been great to be able to offer and stand up. We touched over 800 templates for our providers within a matter of 4 weeks and had those changed. So really great effort and work there. Next slide.
So as we, I think all struggle with finding positives across the spectrum of 2020, one of the highlights that showed up midsummer was a benefit in the reduction in patient miles traveled, and then the resulting impact on their time, and so on. So 13.7 million miles, which is a huge, I think, opportunity and a positive statement about, another value of telehealth here. We looked at every patient's home address, connected them with the clinic who provided their telehealth visit, and tallied up quite a savings there. And just putting some average distances on that, we saved a lot of travel hours, and we saved a lot of time on the road. So far, a running total of about 27 years worth of travel through the telehealth deployment. We've connected with patients in 49 states, so we can't underestimate the reach with which we can connect patients via telehealth. As we think about that 13.7 million miles, it's interesting to look at some of the calculations on that. I think this brings it home when we talk internally about, another value of telehealth. I'll point over there, on the, the number of smartphone charges. 700 million smartphone charges is basically what that, correlated into. And then our sustainability department here in the medical center, very excited about, just the result we can have with, this kind of a ongoing effort here. So I think another message we probably haven't really thought a lot about, but when you tally it up, it really starts to make a difference.
And then we wanted to engage with marketing as well. So Brian mentioned marketing throughout this conversation, and they were really vital to our interactions with patients. And, as you're moving through things rapidly, you think, I've thought through every scenario. This is great. No one's going to have any issues with this, only to find out you forgot something. So we wanted to make sure that we had the voice of our customer in mind and that we were getting their feedback. We did a couple of surveys. Some were focused internally with our physicians, our nurses, APPs, and frontline team members to hear what they thought of telehealth and how we could improve. And then we also looked at our patients and did a patient survey to understand what their thoughts were. So, of the patients who completed video visits, for this survey, we looked at about 1,400 patients and got their feedback. Some of the things that we heard is that, the most valuable aspect of telehealth is that they aren't going to catch an illness. They aren't going to get sick. But some other key points that I think are great to hear about, and probably of no surprise to us, are seeing their provider regardless of where they live or where they're at. Less time spent waiting, right? We always hurry up and wait no matter what we do. Time and cost of transportation. And this is one that really reflects in Brian's previous slide. When we think about the number of miles saved, we aren't even talking about the cost savings for those patients when we think about that. So that's a really great aspect of it as well. And when we're talking about COVID and the number of people who've lost their job or are financially really strapped compared to maybe where they were pre-COVID, or were already strapped to begin with, and now that is just another burden that they have, the ability to take less time off of work seems great. On-demand access to care, and then just thinking about childcare, and we have that little bucket of other there. Next slide. So what our patients have experienced. So we do want to understand, where we have opportunities to improve as well. When we look at our different platforms, we wanted to understand maybe how that experience varied. So when our patients were connecting with the My Health app, which is our OSU app that we use, or the medical center app, there were 17% of patients who had technical issues. 20% via UpDocs or our third-party vendors, and 30% via the MyChart desktop. The MyChart desktop was really surprising to me. I thought most people would be more comfortable with that desktop scenario, but it was actually more challenging for them versus the mobile devices that they could utilize. 23% technical issues overall. When we look at this, that doesn't sound great. I'm sure Brian, hates that I'm saying it right now, but it's new. And when we work with technology, we are going to have issues. So to expect this to be zero is unreasonable, but we want to understand what those issues are so we can try to reduce them as much as possible or resolve them quickly. Speaking of resolving them, 50% of the patients who said they had issues said the issue was not resolved. I do want to drill into this a little bit, and I'm going to make some assumptions here. But when we talk about how we set up our process for our providers and clinics operationally, I can understand why 50% of patients may say their issue is not resolved. What this does not mean is it doesn't mean the patient didn't have a visit or didn't get taken care of that day. It just means that they didn't get taken care of via that original platform, or that original issue wasn't addressed. So what we set up as a workflow for our providers or our clinics when they were having technology issues is, as we said, the goal is to start with video visits. So if you're starting with a video visit via MyChart, your default, if you're running into issues, is not to spend a bunch of time in a 15 or 20-minute visit, focus on the technology and fixing it. Go ahead and default to an UpDocs or third-party visit, which sends out a link to a patient, they click on it, and that process seemed to be a little bit easier for people to grasp. If that's not an option, people are flustered, don't worry, we always have telephone as an option to complete our visits. So we want to make sure that that visit is taken care of. Again, telephone is our last option, but it's still there and available. So we feel a lot of these issues weren't maybe resolved, but the patient was still taken care of via a different product, including telephone visits. Next slide. And then what our patients are doing next. So we wanted to also understand how their experience was. Again, a few people or quite a few people had some kind of technology issue. Would they do it again? 90% would recommend a telehealth appointment at OSU. So that's great to understand, saying they had a good enough experience that they're going to go talk to others and recommend that same opportunity for them. 87% would likely choose telehealth again. And 74% are still interested in telehealth appointments even after a vaccine is available. Pre-COVID, we found that this was estimated at about 45%. So just from the situation of all of us maybe having to be forced into utilizing telehealth, we found that, hey, it's not so bad. It's actually nice and convenient, and our patients like it and our providers like it. So we have really invested in making this a foundation of our care. Next slide. We also wanted to look at, in general, what's happening. What are people searching online? And we can see that, even with the initial spike of COVID, we are still seeing a lot of searches throughout the system for telehealth and what options are available to patients. So these are Google searches that someone's entering this information for. Next slide. And then we have some information from Kairos that indicates 50% of patients are willing to switch providers to have virtual care. As someone who is accountable to access, this is significant. We often feel like once a patient has seen a provider or has engaged with an organization, they're pretty committed to that organization or provider. And it's going to take quite a bit to have them switch to someone else. But what this tells us is that our patients may be more likely to switch if we aren't able to meet their virtual care expectations. So we want to make sure that we can do that by expanding our offerings of providers. As I said, having that ability for patients to schedule themselves for telehealth and make those choices, as well as even offering on-demand type visits. Next slide.
All right, so really coming back to technology and what's next, I'd like to kind of build on something Brooke mentioned, that we had some challenges with technology, and I think it's important to think of telehealth in your institution as almost like one big virtual clinic, and that clinic has a front door and it's got exam rooms that all happen on these devices. And we really started to recognize that we've got to build redundancy and efficiency in that process to make that clinic better. We've got a situation right now. We have multiple vendors inside the organization. I'm not sure that ever really goes away because, as I mentioned, if you think about this in terms of a virtual online clinic, if the front door to that clinic goes down or the hallway to the waiting rooms is somehow clogged up, you're going to need to create other hallways to create that path of least resistance, because our providers are certainly creative and incentivized now to enable telehealth. And they're thinking about ways. They're looking at some of the other video technologies that are coming in, not only from our institution, things like Teams or Zoom that we're using right now, or they're looking at other vendors. Doximity, for example, is a vendor that targets specifically the provider and had not historically really worked at an enterprise level, but that very quickly came up as an option for some of our providers there. But all in all, we're trying to look for that optimal single solution, something that creates ease of use, because it's got to be as efficient and effective as an in-person visit, that type of fluidity and agility to really help continue to embrace provider adoption of that. Reducing confusion, monster learning curve. I think if we could actually put a bell curve to how much we all as citizens here learned about video technology, it would be quite a steep curve there in that May, April, June timeline. as we all began to work more from home or in virtual environments. Challenging our carriers to look at network congestion. We had situations even in here in our our own networks. We started to just identify how to continue to refine that. And our network team has been great about building in redundancy and ensuring that they've got streamlining in those places. Compatibility with client devices. I don't know about you all, but I have family members who are still, I've got one on a flip phone. I've got others who like to get the latest device the moment it comes out. We're challenged as an institution. I used the Verizon example earlier. We have to make sure that we've embraced as many devices as we possibly can. But going back to some of the backbone technologies, which aren't necessarily controlled by UpDocs or Epic or those vendors, it's making sure that those underlying solutions are really meeting our patients' needs there. The communication experience, be it training up front or streamlining or simplifying the expectation about what to do at a video visit and how that's going to work with us, is going to be an ongoing thing we'll press into in 21. Then, of course, augmenting telehealth. Certainly completing a chat and a visual type of an exam is the first step. We're now looking at partners to connect the ability to do, can I check your heart rate? Can I look at your temperature? Let me look inside your eyes, your ears or your mouth, something like that, and really helping enhance that experience. That, of course, will help lead to better payer adoption. As payers feel like those visits are on par with an in-clinic experience, we feel like we'll get better movement there as well. But we continue to compile a working list. I think I have 25 wish list items as we continue to look for that silver bullet solution that really meets all those needs. And that's going to be an ongoing exercise for the institution as we continue to meet and get into the next part of the next year. So, all right, with that, Rob, we're going to jump down and go to questions. We appreciate everybody joining us here today and hope that you've learned something from our experience. And if you have a unique experience of your own, reach out. We'd love to hear about it.
Thank you, Brian and Brooke. That was great. And even though I'm within the organization, I've learned a lot from what you shared. So thanks for both of you for sharing with our Central Ohio community, and certainly for everything you have done for our own organization. Are there questions from the audience for our presenters? I'm monitoring the chat here. I'm not seeing anything, but you're welcome to unmute and ask.
We caught them before lunch. Everybody's anxious.
Everybody, yeah.
Hey, so this is Abigail with UC Health that I was on earlier. Are you still attempting on your third-party workflow to collect consents or HIPAA forms? Do you still try to attempt that? And if so, how are you doing that?
Yeah, I can take that one, Abigail. So this is Brooke. We do attempt to collect verbal consents for every patient who's engaged in telehealth. And that includes consent to bill, consent for care, as well as a telehealth consent. That is done during our scheduling process. If not, we're doing it during rooming. And I wanted to mention this and I forgot, but we also developed a centralized telehealth rooming process. So that is something that's more recent, but we have our MA team doing all of the rooming for telehealth so that they can identify anything that's missing, review that with the patient, get it during that time of rooming, as well as identify what state the patient is in and escalate if there are any concerns. For example, yesterday, one of the MAs reached out to me and we found out that we have a patient in a state with a provider who's not licensed in that state. So we were able to convert that over to an appropriate type of visit for the patient, meaning in person, to have that completed for them. So we do have that process in place. And then also with centralized scheduling, they're getting that every time. They're also completing the hospital account, so the HAR, and doing a full registration on those patients. So our contact center teams do have a little bit longer call time, but we feel like it's really important to get that up front so we know every interaction after that for the next year is covered.
And then, so your central scheduling is actually reading, are they actually reading some type of consent? Okay, and then so where does that get documented if the scheduling team is doing that? Do they document in the same registration table for consents?
They
Okay.
do. Yep. So we have the verbal consents along with the signed consents that are right there. And the verbal consent has the person who's gathering that document, who they received it from, and then their information as well. And that's in the same table. So if that patient went for an in-person visit, it would be right there for them to be able to see. The patient can go to the website to see any of our consents as well if they wanted a copy of all the details of it.
Okay, yeah, we've done that too. And then when you mention MAs, are you saying MAs within the department or MAs like with you, with
With
your
me.
team? Oh,
Yeah,
that's interesting.
so we
Okay.
have a centralized team that we've developed that are doing that rooming. We're at the very beginning stages of that. We don't have it fully up and running, but they're going to manage all of the telehealth visits and do the rooming there so that they can focus on the specialty pieces of how the patient is connecting, where they can go, the out-of-state requests, as well as trying to collect vitals for someone over the phone. So having some of that, and then allowing our in-person clinics to have an MA who's focused on the patients who are coming in the door, rather than having to focus on the people coming in the door as well as the telehealth that needs to occur.
And then for your out-of-state licenses, you mentioned that. What system process are you using to cross-reference those PHE registrations? So at the time of scheduling, they're asking the questions, the patient states, oh, I'm going to be in, West Virginia. And then do you have that integrated into Epic, or do you have it separate, like in Cactus or another place where the MA is then looking, cross-referencing?
So for our schedulers, we have a decision tree within Epic for our telehealth visits that helps flag them right at the beginning to understand if that patient's going to be in the state of Ohio. If not, or if the patient states that they will be in Ohio and that changes, we have scripting and information that goes out to them. And then our MAs, when they're calling, they have a resource document on our intraweb that they can intraweb, what's it called, Brian? Well, anyway,
You got it.
whatever Brian says it is, that
I know what you mean.
that they can pull up and is automatically, or not automatically, but is updated frequently, and then they can compare that state to understand. The next phase of what we're looking at, though, is we don't have for every provider what state they're licensed in, which I think is maybe part of your reference to Cactus. So we are looking at building into our SER records within IHIS the information. So if I have a patient who's seeing Dr. Smith and they live in Florida, I'll automatically be able to know, is Dr. Smith licensed? Does he have a Florida licensure? And if so, then we could continue on and we aren't going to flag that anywhere. If not, then we're going to have the flag in the communication that needs to occur. So we are looking to house that in our system, our EHR Epic.
Okay, thank you. Yeah, we have the decision trees too. I think the challenge is the second piece, who is managing the tracking and cross-referencing, and then who's uploading it, and if the providers are doing it on their own, what are they doing with their paperwork? Okay, thank you.
Yeah.
So we have another question in the chat. As humans and having the same fears as others, some of our physicians desire to do more work from home. We are in a rural area and some of our physicians utilize known slower connections such as DSL and satellite. Did you run into anything like that? And if so, how did you address?
We did, and it's actually still a challenge. In some cases, there's only so much you can do. A satellite interface in a lot of cases is part dial-up and part satellite, connection. DSL, a little more stable, but doesn't have quite the bandwidth there. And unfortunately, those are situations that from a technology perspective, they create certain limitations. There are the video visit technologies, and UpDocs in particular has done a great job of having a self-throttling video. So it will continue to stage better quality video as the bandwidth speed comes up, but it has a certain minimum threshold that it needs to maintain a stable connection. I'm sure anybody on this call has been part of a video effort where the audio got choppy or the video starts to pixelate and lock up. And that's certainly a quality of service opportunity as we look at that. We did have, a candid dialogue with a couple of our docs about trying to get them to satellite clinics where they could get to a hardline connection that, was more enterprise grade, and try to provide them some privacy in that setting. But it's still something we're continuing to learn from. And I know in talking with the carriers that we have relationships with through Ohio State, they're continuing to do more to help build up that network, because we've got a whole population in Ohio. This is the southern central Ohio group. As we get down towards Hocking Hills area and Southeast Ohio, they don't even have hardline networks that are really pulled into some of those communities, much less having, a broadband Wi-Fi type of a network. So I think it's going to be a long-term opportunity for the state in technology investments.
Thanks, Brian. I actually have a question for both of you, just which I hope is applicable to everybody. But what are the conversations? And Ohio is mostly Epic. The conversations with Epic to make this this technology more accessible and user friendly. For better or for worse, we've had to use, and I think one of our other speakers had mentioned that we're never, maybe it was you, Brian, that we would never get away from, using multiple platforms to do telehealth visits. And what is kind of Epic's stance on that, and what are they doing to make this easier? And I think this is particularly in kind of, context aware and multi-party type of visits that we've had to use third party for. Sorry.
That's a tricky one. I don't want to speak for, Epic's future design and development. We at Ohio State have, know, as I'm sure many of you folks do, Epic is working on their own video visit product. It's been deployed to some pilot audiences. We're continuing to watch that. Certainly having integrated Epic workflows really is the most optimized environment. You get, get an ease of clinician use, you get all of the record content. I can streamline screenshots, directly into the, the record. So there's a certain value to that. But strategically, we have to be mindful if any part of that interface or network goes offline, or if we're in a situation where even maybe the physician is working remotely and loses connectivity to the medical center, maybe because of a ransomware event, God forbid, something like that, it leads into the need to continue to buffer and put redundant communication, technologies in place, at least at some level. Now we have to be thoughtful. These technologies, of course, have a cost. Fortunately, in the scheme of, healthcare, video visit technology has been a little easier to digest than probably, some other portions of our deployment and infrastructure. But I think it's going to be something we'll continue to cycle through. I don't know that there's ever going to be one fixed answer. I think at some point, particularly with the clinical device augmentation, as we expand the types of things that you can do remotely, that will challenge us to make sure we've integrated the connectivity and the solution in the most appropriate way to meet the patient and the clinician's needs.
Mm-hmm.
Thanks, Brian.
Epic, this is Abigail. Epic does have features coming out soon where they are offering the direct email link and texting link. I think it's supposed to come out this month. So that will kind of put them on par with Doximity and the other, third-party vendors. So we'll see how that goes.
Yeah, our biggest concern there is getting MyChart adoption rates up, because all of that requires a MyChart account. And if we have patients, either because of device or preference, who are not enabled with MyChart, we've still got to think about ways to bring those.
Their direct link option does not require MyChart.
Oh, I hadn't heard that. That's good.
Yeah, it's the new one. And then their next rollout, I think in March, would be incorporating that with MyChart and eCheck-in.
Gotcha.
So we are right at time. Again, I want to thank Brooke and Brian. Great presentation. And I am certain that either one of them would be open to having questions from others, I know. So this is a great opportunity to network amongst our organization. So thanks again, Brian and Brooke. The next session is actually a CIO panel where I expect some of these same topics will come up, and also a scholarship presentation. So for a few students, so I'd encourage everyone to hop onto the other Zoom. And thanks everyone for your participation and questions. Appreciate it. Have a great afternoon.